Let's go to the beginning of the video. Go to the very, very beginning of the video, like 001 seconds, and then hit play. Now hit play, we're done. Awesome. So I'm talking, obviously, my favorite topic ever is challenging cataract cases. You can hit play on the video. Hit the play button and then just don't touch it no matter what. Did you hit the play button? No. You need to hit the play button on the video. There we go, now we're talking. So I love challenging cataract cases. That's my favorite thing. And so the first one I'm talking about is a complication. So I was talking to a surgeon yesterday, a very experienced surgeon who's done 100,000 cases. And we both agreed that sometimes you just can't predict a complication. So I'm going to show you in a case here. In fact, you know what? We're going to speed up my video. Can we do 2x for the video? So we're getting the rexes done here. It looks like a routine case. But it's important that we learn from every case. And so one of the most important principles is recording every surgery you do, because you never know when you're going to hit a complication. Hey, audio video, can you do 2x speed on this? So here's a routine case. This is a Beverly Hills type cataract, not too dense. I know my Indian colleagues say, where's the cataract when I show a case like this? But you'll see it's a lot of posterior subcapsular cataract. There we go. Here are the young doctors. Come on in. And so at the end of the case here, you'll see it looks pretty routine. And we have a very high volume surgery center. Our surgery center in Beverly Hills does about 20,000 cataracts a year total with all surgeons combined. So we obviously are very efficient at surgery. Did you figure out 2x? Hey, my friend, did you figure out 2x, how to speed up the video? And so here's the case where, watch carefully, you'll see that's not what we wanted. Okay. Well, in this case here, let me show you where I have a complication. The complication comes when we're aspirating here. We can take out the cortex, and then you'll see in the posterior capsule, you haven't figured it out, right? You don't know how to do 2x? I can teach you, but then I'll have to take your salary. So watch carefully as I take out this last little bit of cortex here, and we would all do this. We'd go there and look at the posterior capsule, that one little tiny fragment of lens material which I'd like to aspirate. And as I go to aspirate it, watch carefully, I think I'm just gonna get that one little piece here, and as we do so, the capsule opens up. So what do you do now, right? Well, the key is how to react to a complication. We all have complications. So watch carefully, there's nothing I could have done here. Aspirating this little tiny tag, this is at 1/4 speed, and as I go to grab it, you'll notice right there, boom, capsule's open. Now what? Well, the key is obviously to react appropriately. So stay in the eye position 1, keep the infusion on, and now inject some viscoelastic. Well, I can keep the anterior hyaloid face intact. This patient will have 0 vitreous prolapse. So there's the viscoelastic going in here, keeping the eye pressurized. Don't let the AC pressure go to 0. You want to be able to prevent vitreous prolapse. And now what can you do? Well, I have a totally intact anterior hyaloid face here. So I'll put a little more viscoelastic. Well, why don't we put a 3-piece lens in? I've got a beautiful capsular rexus. And so what we're going to do here is just slightly enlarge the incision to allow us to easily place a 3-piece lens. Now, a mistake that I would have made in the past would be to try shove the 3-piece lens through the smaller incision. At this point, I know better. Just slightly enlarge the incision so you can be as gentle as possible. Even in this case with an open posterior capsule, I'm telling you the anterior hyaloid face is intact. And we'll be able to get a 3-piece lens with haptics in the sulcus and optic captured and have a beautiful refractive and visual outcome the next day. This patient was absolutely spot on target, 6/6 vision the next morning. So here I'm just using my diamond keratome to slightly enlarge the incisions. I'm in Beverly Hills, so I like diamonds, so I'm fancy. That's a joke. And so here comes the lens. Now, when you put the 3-piece lens in the eye, you have to go back to your simple concepts of the 7L rule, right? I always teach on cataract coach, the leading haptic better look like a number 7. There it is. And then the optic comes out, and the trailing haptic like the capital letter L. That's the 7L rule. So, right, the eye wall haptic should not look like an S. If they look like the letter S, I'm making a stupid mistake, so I don't want that. So there you go, optic captured behind the rexus. And you have a beautiful outcome here. Notice here at the end, I'm going to hydrate up the incisions. just to make sure. Why do I want to hydrate the incision before removing viscoelastic? Well, as I take out the viscoelastic and come out of the eye, I don't want the AC to shallow or collapse. Right now, the vitreous is intact, the anterior phase is intact, there's zero vitreous prolapse. I want to keep it that way. And then I just think of the good part. This patient's never going to need a YAG laser capsulotomy. So think of the good thing there. And so we'll finish up the case here. I'm going to get through this a little faster for the benefit of time here. But you can see we'll finish up the case and the outcome's pretty nice. And then let's do this. Let's fast forward here. I'm going to show you a different case. Let's fast forward to something that's more complicated. So we also have to learn new techniques. We can't shy away from that. So what I mean by that is here. Here's a patient who's going to get Gore-Tex IOL fixation. This is a patient who came in, and you can see, if I use the traditional way of Gore-Tex, it's under the conj, it's above the sclera. That's terrible. That's going to erode away with time. And you can see patients like this where the Gore-Tex has eroded away. You just can't leave it under the conjunctiva. So in a case like this, what we're going to do is we're going to pass intrascleral Gore-Tex. This is that 8.0 Gore-Tex on the CV8 needle. And so as we pass it, this is only going through the sclera. So from one potential sclerotomy site to the other, between the two sites, we have a pass of Gore-Tex. Now we can enter in and bring it out the incision, and you'll see, here we go. And in this case, we had to do a scleral tunnel and a larger incision because the patient had a PMMA AC IOL that we removed. So now you can see how we place the Gore-Tex, and I'll show you at the end here a diagram of exactly how to do it. But the key here is to be able to learn new techniques and not be complacent with what we're just doing from the base. No one taught me this in residency. This is just not taught anywhere. So you have to watch videos on your own and learn. That's why people love Cataract Coach. So I'll pull this through here, and you'll see we'll get the two ends in. We'll get the IOL. This is a 4-point IOL. There are many IOLs on the market here in India that have these 4 eyelets. And you can see now, look, we have both Gore-Tex sutures coming out of a single sclerotomy site. And as a result, when we tie this knot down nice and easy, we'll get the lens centered, and this will be permanent. The knot will be inside the eye. There will be zero visible Gore-Tex suture. So again, we're tying it up. Remember, the Gore-Tex is very slippery, so make sure the knots are tight and secure. Nice and tight. Leave the ends a little on the longer side. And do the same on the other side. There we go. And so this is a case where I taught one of the UCLA residents. I've since retired from my job at UCLA, and now I'm actually going to I'll start teaching the University of Iowa residents later this year. So there we go, rotating those sutures, sealing it up, and let me just show you how we did it. At the end here, we can remove the viscoelastic. Notice the knots of the Gore-Tex are placed within the sclera. And so again, finishing it up here, and I'll give you a diagram of exactly how to do this. So this is a technique that was pioneered by a New York surgeon named Jamin Brown, a retina surgeon. But again, a technique we can learn. So intrascleral past the Gore-Tex, here's the diagram. And so you get a tunnel, intrascleral tunnel with the Gore-Tex CV8 suture. And then once that suture is in place, again, we externalize it. You can see the yellow dotted line is the internal intrascleral pass of the Gore-Tex. And now we externalize it, place it through the IOL haptic loops, the eyelets, put the IOL inside the eye, and then once it's tied up, you'll see that's really secure. That lens has 4-point fixation. It'll never go anywhere. Gore-Tex lasts forever. And most importantly, there is no exposed Gore-Tex at all. So when you look at the side of the slit lamp 6 months or a year later, you have no idea how the eye was fixated, unless the patient, of course, dilates to a huge, 8 millimeters or so. At the end here, we can close up the conj and we can call it a day. And you can see there are 1, 2, 3 instruments here because this is me teaching a resident. So at the end of the case, it looks just fantastic, and patient had a beautiful outcome. And then for the very last thing I want to tell you is just be open to learning new things. Now, we were always taught how to do IOL exchange or cut the IOL inside the eye, fold it in the eye, but maybe there's another way. So here's a way where we can just actually twist it out of the eye. So grabbing the edge of the optic, so this is me operating, and I'll show you a resident case too, using a chopper here to get a better grasp. And notice I'm not grabbing the middle of the optic, the edge I want to grab. I have one haptic outside the eye. Now using the spatula to protect the cornea and help roll the lens, we respect that cornea. We don't want to touch the cornea. We can rotate our hand, pull it out of the eye, done. You can pull this out through a 2.2, 2.4 incision. I usually enlarge the 2.75 or 2.8, but you can pull the whole lens out intact. We published this paper long ago, although I'll tell you, peer review is one thing, but if you want people to know about it, make a video. It's far, far better reach. So start with your hand supinated and you just pronate your hand. Here's a resident operating. So this is a resident doing this case, and you can see grabbing the edge of the optic there, using the spatula to protect the cornea. Of course, the AC is full of viscoelastic, so rotate. Let's get that spatula positioned. Rotate, 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 and you can just extract the whole lens very easily. And for the last few seconds of my talk, and I'm way ahead of schedule, which is great. Again, external view, look at that. It just rotates right out of the eye. So bottom line is just keep learning. That's the reason I do Cataract Coach, a new video every day, because I want to learn. So thank you guys. 2,100 videos and counting. You can stop. We're done. All righty. Thank you guys. Any quick questions? We're a little ahead of schedule. Otherwise, I'll run to the session you arranged for me. All righty.
May I ask a question? We are all fans of Uday and Cataract Coach, and thanks a lot for giving us the Cataract Coach. About the twist and rotate, the forceps is a specially designed forceps?
No, anything. Straight tying forceps.
Straight tying forceps without any ridges on it?
No, just straight tying forceps. That's it. Cheap, easy to do.
Wouldn't
let me go, because she's going to take me to the next one. But the video's on Cataract Coach.
Okay, thanks.
So our next speaker is Professor Anthony Aldabe. He is the chair of UCLA Jules Stein's Eye Institute, Los Angeles. And he'll be speaking on congenital hereditary endothelial dystrophy. And for 15 minutes, yeah.
Thank you very much, Dr. Basak, and I really appreciate the invitation to be here at the meeting, and I thank you for coming to the session today. This is the first time this data has been published, or presented rather, in public, and hopefully you'll find this of interest. This is preclinical results of SLC411 gene therapy for congenital hereditary endothelial dystrophy. By way of disclosure, I receive grant support from the California Institute for Regenerative Medicine that supports the work that I'm going to present to you. So you are more familiar with CHED than I am. Congenital hereditary endothelial dystrophy is an autosomal recessive disorder that's associated with congenital corneal edema, more common in India than it is in the United States, where it's a fairly rare condition. This paper published by Dr. Ramappa and colleagues at LV Prasad a couple of years ago in Cornea described outcomes of DSAC in a pediatric population. In this paper, they reported on 180 procedures performed in 167 eyes, and 116 of those procedures, or 70%, were in children with CHED. So this paper gives us a good idea regarding the outcomes of keratoplasty for CHED. As you can see on the Kaplan-Meier survival curve here on the right, the solid line represents graft survival, and we note that at around 10 years that the graft survival is only 50%. So considering the average age at the time of transplantation is 8 years old, this means that half of the transplants have failed by the time these children become 18 years of age. We know also, of course, that subsequent corneal transplants are likely not to last as long as the initial transplant did. This is a child I saw in Saigon who had had DSAC performed for CHED by another US surgeon. You can see in the right eye, which the graft has failed, the vision here, hand motions, much more opacified than the unoperated contralateral eye, which the vision is 2200. So in this case, the child did not have a repeat transplant because no tissue was available. So given the scarcity of corneal tissue in many regions of the world where CHED is most common, given the increased risk of rejection and failure of keratoplasties in the pediatric population, and given the fact that even in the best of hands, the graft survival of DSAC is only around 10 years on average for CHED, we clearly need to develop alternative treatments for management of corneal edema associated with CHED. So what is CHED caused by? CHED is associated with mutations in the SLC4A11 gene. And there were several groups, including some investigators from India, who were involved in describing the genetic basis. How do mutations in SLC411 cause CHED? Well, you have to ask, what does CHED do in the corneal endothelium? One role of the gene encoded that's involved here, SLC411, is in keeping endothelial cells viable. So what we did is we showed in this paper that was published recently in PLOS ONE that endothelial cells in which you have absence of SLC411 have decreased cell viability, shown here in the white bars. When we mutated SLC411 in these endothelial cells, what we've shown is also that, again, the endothelial cells have decreased viability. We can see that associated with a number of different mutations that have been identified in individuals with CHED. Additionally, SLC411 is involved in the barrier function that endothelial cells have in the cornea that help keep the cornea clear. So if SLC411 is mutated or knocked out, we see decreased cell barrier function. In this graph, we can see where this is impedance, so it's measuring the resistance to a current across the monolayer of endothelial cells. And we note in the gray curve that when we knock out SLC411, that barrier is decreased. Additionally, we know that endothelial cells help maintain corneal clarity through a pumping function, and SLC411 is involved in that as well. We note that when we mutate SLC411 or we knock it out, that membrane conductance is decreased. In endothelial cells in which we've knocked out SLC411, we see, following exposure to ammonium chloride, a hyperpolarization as opposed to a typical depolarization in cells expressing normal wild-type SLC411. So if we want to learn more about the role of SLC411 in the endothelium, what we do is create an animal model. And that's exactly what colleagues at Arangathanan and others in Singapore did, is they created a knockout model of CHED in a mouse. And you can see in the OCT images here on the top row is the cornea, the thickness, or measured by by OCT, all the way up to 50 weeks of age. The row below that is in a knockout mouse, which shows progressive corneal edema over time. Same thing is plotted here, where we see time on the x-axis and we see corneal thickness on the y-axis. We see this progressive increase in corneal thickness in that mouse that mimics what we see in infants and children with CHED. Now, we also know, recently learned, that boys are affected more severely with girls than CHED. Using data in the published literature as well as unpublished data from a number of different colleagues here in India, we plotted out the thickness of the cornea in boys and girls with CHED, and we noted, for example, at 11 weeks, a significant difference in the corneal thickness, with boys being more severely affected than girls. So the question is, does this CHED mouse also demonstrate this sex-related difference? And in fact, it does. Here we see a graph of central corneal thickness against the age of the mice. The bottom line we see here with the solid circles are the wild-type male and female mice. You'll note there is no difference in the corneal thickness between the male and female wild-type mice. However, in the knockout mice, we can see by the dotted blue line here representing the knockout male mice, and the red line, the knockout female mice, that there is a significant difference. So we see this sex difference not only in affected infants and children with CHED, we also see it in our knockout mouse. So in a very important paper that was published a couple of years ago in Journal of Ophthalmology by Joe Bonanno and colleagues, what they did is they took initial attempt at gene therapy for CHED. They used AAV9 virus carrying the mouse SLC411 and performed a single intracameral injection in one eye of the knockout mice. They then followed these mice over time, and you can see at week 4, the thickness in the non-injected eye, the thickness of the cornea, is significantly greater than the corneal thickness in the eye that had the single intracameral injection. So good initial evidence of the efficacy of replacement of the SLC411 gene to increase endothelial function. Now, we thought that perhaps you could get better transduction of the endothelium using an intracameral injection, intrastromal injection, as opposed to intracameral injection. Dr. Bonanno's group estimated that with the single intracameral injection, they're able to get virus and gene into about 25% of the endothelial cells. So what we did is we performed a single intrastromal injection, this time AAV8, and this time we're using GFP, green fluorescent protein, as a marker of where this virus goes. And we showed with a single intrastromal injection that we're able to get the virus into about 50% of the corneal endothelial cells. So this confirmed our belief that we could probably get better effect with an intrastromal injection as opposed to intracameral injection. But the question is, even if you're able to put the SLC411 gene back in the endothelial cells in infants and children with shed, will that gene encode a protein that then functions? And so what we did to test that is took a corneal endothelial cell line in which we knocked out expression of SLC411 using CRISPR-Cas9 targeted genome editing. We then replaced SLC411 in these cells to see if these cells then regained normal function. So you can see in the knockout cells that hyperpolarization that is characteristic following exposure to ammonium chloride. And when we replaced SLC411, again we see the normal depolarization, showing that we've replaced or repaired membrane conductance. Also, we showed that we could increase cell viability in these endothelial cells by replacing SLC411. So good evidence that, yes, replacement of the gene does help restore endothelial cell function. So given the fact that we've shown data that intrastromal injection can transduce the endothelial cells effectively, given the fact that we've shown that replacement of the gene restores endothelial cell function, we felt like it was time to go to an in vivo model. So we looked to evaluate the efficacy of a single corneal intrastromal injection of recombinant AAV8 encoding SLC411 in one eye of these knockout mice at 4 weeks of age. We tested 4 different dosages, and for each mouse, the eye receiving the injection was randomized, and the contralateral eye served as a control. We used anterior segment OCT before injection and following to measure the corneal thickness biweekly. We also performed anterior segment slit lamp examination retinal OCT biweekly after injection to monitor for toxicity and a host immune response. So what did we find? Well, at the highest dosage that was tested, 1 × 10⁹ viral genome per eye. We see here on the x-axis post-injection week. On the y-axis, we see central corneal thickness. The black line is the eye receiving AAV carrying SLC411. The gray line is the control eye. We see a significant difference between the 2 eyes as early as 6 weeks following injection. We actually see a reduction in corneal thickness following AAV injection, and then a stabilization out to 18 weeks. In the untreated eye, we see progressive increase in central corneal thickness. This was seen in both the male and the female mice, but you notice a significant difference in the male mice that is not as dramatic in the female mice. So gene replacement therapy looks to be most effective in the male mice and may be the case also for male infants and children. Looking at the data now at 3 different time points, baseline, week 10, and week 18, we note the female and the male mice. Here, the black circle is the AAV eye, the gray is the untreated eye. At baseline, the same. At week 10, we see an increase in the untreated eye in the female group as far as corneal thickness. Same in the male group, but also, as we've been talking about, much more significant. At 18 weeks, we see a pronounced difference in the corneal thickness in the mouse between the treated and the untreated eyes, with less of a difference in the female mice. Here's just an example of these 2 eyes of a mouse at week 14 in panel A. Of course, this is the control eye, and on panel B, the treatment eye. So this is a significant difference that we're seeing following this intracameral injection. We looked at 3 other dosages. With each of these dosages, again, we see a separation between the treated eye in the black line and the untreated eye in the gray line as early as 6 weeks following injection. And again, each of these dosages, we see a greater difference in the male mice than in the female mice. So this is at 1 × 10⁸, and then finally 1 × 10⁷. So we're still looking to see what is the minimum effective dose. This is the lowest dose we've tested so far, and again, we're seeing efficacy that is sustained out to 18 weeks following a single injection. So as far as to quantify the difference in corneal thickness, at the highest dosage, we see 33 micron difference at week 6 between the treated and untreated eye, and that difference is doubled by the time we get to week 14. As I mentioned, in each of these dosages, we see a difference, separation between the treated and untreated eyes by week 6. So our group was selected by the Foundation for the NIH as to be part of this bespoke gene therapy consortium. This is a public-private partnership involving the NIH and multiple companies, industry, et cetera, with the sole purpose of trying to accelerate gene therapy development for rare inherited disorders. And so we're very proud to be one of 9 groups nationally to be part of this, 3 groups involved in vision science research. So with support from the FNIH, part of the Bespoke Gene Therapy Consortium, and with funding from the California Institute for Regenerative Medicine, we're currently conducting these preclinical tests, and we hope to have a pre-IND meeting with the FDA in about 1 year. We then anticipate submitting an IND to the FDA in early 2026, and if we attain approval, we will begin first-in-human clinical trial in 2027. The clinical sites will be UCLA, our colleagues across town at USC, and hopefully our colleagues at LV Prasad, Dr. Ramappa, who has the world's largest collection of children with CHED. We'll acknowledge our collaborators at Stein Institute, Wenlin Zhang and Doug Chung in the Cornea Genetics Lab, Matt Hirsch at the University of North Carolina Gene Therapy Center, and Brian Gilger, North Carolina State University as well. Our funding agencies, of course, without them, none of this work is possible. I want to acknowledge the Bespoke Gene Therapy Consortium of the FNIH, CIRM, the American Society of Gene and Cell Therapy, and funding as well from the Research to Prevent Blindness. I'd like to thank all of you very much for your attention.
Thank you, Dr. Aldabi, and this is a fantastic. You have any question, Banati? Want to ask any question to Aldabi, or anyone want to have any question? This is a wonderful area of
yes, I think it's wonderful. It's phenomenal work, and we are looking forward to the clinical results. I think that's when all the hard work in the research really translates, and it would be wonderful if we can really break through in this, because as you stated, D-sex and D-mex in CHEDs, it is always you would always look at a higher failure rate as what you would look at in adult patients. Thank you so much for that.
Thank you. And then, of course, CHED is a relatively uncommon condition, but this is the goal of the Bespoke Gene Therapy Consortium is to have these 9 different groups sort of pave the way to streamline development of gene therapy. So if we can show efficacy for CHED with intrastromal injection, the next disease that comes to mind for me is macular corneal dystrophy. Again, where you're going to be replacing a deficient protein, in that case CHSD6, same approach. And something I think will hopefully open the door for treatment of other inherited disorders of the cornea. What's held us back, I think, in cornea as far as gene therapy is the fact that we have treatments. We can do corneal transplantation, so there's been less of a need or a push to develop gene therapies like our retina colleagues have. But all of us, of course, who do corneal transplants know all the problems associated with corneal transplants and the poor outcomes, especially in the pediatric population.
Thank you. Thank you so much.
Thank you.
So our next speaker is Dr. G.N. Rao. And it's at that side. So he'll be speaking on primary eye care, where the difference can be made.
Sorry, Tony, I have to take you down to the bottom of the pyramid now. Anyway, fantastic lecture. On behalf of Indian ophthalmology, I have to offer one apology to you, though. To listen to you, this hall should have been overcrowded, but we have an embarrassingly poor attendance. Apologies for that. So, switching gears from the horizons of what is happening in gene therapy for some of the rarest forms of corneal disease to what is out there in the remote, rural, and vulnerable communities of countries like ours. This is the picture of Majuli Island, a river island on river Brahmaputra. You can reach there only by boat. There is no road connectivity. About 7-8 years ago, in partnership with one of the ophthalmologists in Jorhat, a vision center was inaugurated, a primary care vision center. When I attended that inauguration, I thought we have finally arrived. These are the kinds of communities that require our attention, more and more of our attention. And River Brahmaputra, going on the boat, crossing the river, was a phenomenal experience.
Brahmaputra.
So we often hear the world, all over the world, the term universal health care. That is the aspiration of every country from America to Afghanistan. Comprehensive care, commitment to quality, taking as much care as possible closer to the doorstep of the people who need it most. And in our country's case, it's the remote, rural communities where 70% of India resides. A continuity of care, not just ICAMs, with active community participation. If you look at the primary care, it can be divided into two categories. One is community-based, the second is center-based. At the community-based care, we are looking at what we term in our institute's terms as vision guardians. These are healthcare workers who act as volunteers on our behalf, keeping an eye on a population unit of 5,000 people to promote eye health, help in screening programs, making referrals of those people who have any vision problems, and keeping an eye on the two vulnerable age groups post-operatively, the pediatric and the geriatric, and using tools like this, inexpensive, simple tools that will allow you to determine the presence or absence of a possible refractive error. These are then linked to the next level of primary care called a vision center, a concept that we have developed about 27 years ago. And I'm delighted that this has become a catchword all over the world, and thousands of vision centers have proliferated across the world. With a one-year trained technician staffing the center who completed higher secondary education, then the training as a technician, quite often recruited from the local rural communities from disadvantaged families, and giving them a profession. It's a predominantly hands-on training with basic theoretical teaching. They are empowered, and they have career advancement opportunities, with a couple of them in our institute, in fact, completing their PhDs at the University of New South Wales. So there are two types of vision centers that we have evolved over the past 27 years. The conventional ones, where you detect a potentially vision-reducing problem or a vision defect or sight-threatening problem, refer them appropriately or treat them appropriately. Whereas more recently, in the past 5-7 years, we have come to futuristic vision centers, which can not only detect, it will provide follow-up care for a number of procedures, treat certain number of diseases through teleconnection, refer, and reassure the patients. And we have also added a number of different tools, inexpensive but high technology, to detect refractive errors, to be able to do visual fields, and to take retinal photographs and pass it on to the command center at the tertiary level to get the diagnosis and advise the patient appropriately. These primary care centers are part of a system with universal access. In our cases, the primary care vision centers are available to everybody in those villages at no cost. Everybody is screened free of cost. And if all that they require is a pair of glasses, they are prescribed right there and dispensed. If they require referrals at the next level, 10 such centers in our system are linked to a secondary level center where there are ophthalmologists, the care is provided there, and rarely they have to be referred to a tertiary center. And when you look at some of the studies that are published by others, have shown that indeed the case finding and treatment initiation costs are far less in the case of vision centers compared to ICAMs and other approaches. And we also have come up with some innovations of appropriate referrals by triaging these cases. If you say green, they don't need to be referred at all. Yellow needs to be referred within a couple of weeks. And red is immediate referral as an emergency. By approaching this, we have reduced the need for referrals significantly, saving a lot of costs for the patient and their families. The second is the comfort to the patient. And the third, in the modern day world, when we talk of environment, carbon print. It goes beyond all this. It's not just simply refractive errors and giving a pair of glasses or identifying a cataract. Here is a little girl in a remote rural community in Andhra Pradesh who presented to our vision guardian with this appearance. She has immediately taken this kid to the nearest vision center, and the vision technician suspected a possible congenital glaucoma and referred them to the next level. An immediate intervention at that point resulted in what you see on the right. A complete clearing of the cornea, restoration of sight, and we have averted a lifetime of blindness for this kid. And here is another kid who, again, the vision guardian identified to have a white spot in the eye, referred to the vision center. The vision technician could suspect a possible retinoblastoma, immediately connected to our oncologist. It required significant effort from the oncologist, the vision technician, the sarpanch of that village to convince that father for enucleation of that eye and subsequent chemotherapy and fitting with artificial prosthesis. So these are the magical things that can happen at the primary level if we create the proper system of primary eye care in our rural areas. What we have found out from our experience is if you have proper primary care centers with proper infrastructure, well-trained technicians, connected to appropriately placed secondary centers, 80 to 85% of all vision-threatening conditions can be taken care of right in the rural areas. There's no need for any of these people to travel to our big cities with considerable cost savings, and the macroeconomics is even bewildering. But the key factors for the success of primary eye care include proper infrastructure. Like, for example, our vision centers would have the same kind of slit lamp that we have in our Hyderabad campus. And the second is the quality of training of the technicians. It's not just employing any technician and leaving them there. They have to be properly trained. Assure good spectacle supply, the supply chain of very important. Connectivity with the technology, and it should be part of a system. If you build vision centers in isolation, they languish unless they are connected to the next level centers. We now have 263 vision centers as of 4 days ago, and they are rapidly expanding, connected to 22 secondary centers, predominantly in 3 states with a little presence in Karnataka. So, ladies and gentlemen, what I want to say is, while we celebrate tertiary care, we celebrate research breakthroughs in a country like ours, we have to constantly innovate ways of reaching out to the people who are out there living in the remote rural and tribal areas, the very vulnerable populations of our country and many developing countries. In fact, the same applies to many developed countries. Some American friends ask me, how do we replicate this? I tell them, you have all the pieces in place. You just have to rejig your health system and create appropriate structure. Thank you so much.
Thanks, Dr. Rao, for a wonderful presentation and taking care of millions of the patients in an innovative way and economically affordable to the masses of India. And now I'll invite Dr. Awa Hussain the president of Asia Pacific Academy of Ophthalmology, to deliver her talk, Challenges and Opportunities in Preventing Blindness Beyond 2020.
Thank you. Good morning to all. After Dr. Golapalli Rao presentation, I'm thinking in which way I will present, as because his presentation and mine almost not same, but it is very much connected to each other. So my topic is challenges and opportunities in preventing blindness beyond 2020. You see the picture, how dark it was when the granddaughter carrying the grandfather to the center, eye center or vision center like that. And after the surgery, how colorful life is. So, I would like to say a few words about global blind condition, where 43 million people are blind, and among them, 55% are the female. So, 295 million people with moderate to severe visual impairment, and their majority of the people of this visual impairment live in low and middle income countries. So there is a prediction that by the 2050, there will be 61 million people who will be blind. That is Lancet Globe Health. So what about the Asian region? The highest blind people live in the South Asia, that is around 12 million. And the lowest high-income Asia Pacific, 0.53 million. What about the situation of Bangladesh? Bangladesh is a country where the blindness survey has done in 2000, and the prevalence of blindness was 1.5%. And again, blindness survey have done in 2020, where I was one of the advisors there, and the prevalence of blindness was 0.77%. So the number of blind, 50,000, and after 2020 blindness survey, 527,000. You may think why there is minimum difference, as because within these 20 years, the population increases. And so the condition of the blindness survey is like that. What about the cataract backlog? It was 17,400 during 2000 survey, and after 2020 survey, come down to 389,614. So you see, the untreated cataract is now 70%, and the rest are 30%, among them glaucoma 6%, diabetic retinopathy 1%, and in this way others are also. So what are the challenges? Challenges are social, challenges are health system, and others also. Social challenges, that is cultural barrier for not receiving eye care. This is very sad that when people become older, they thought that it is the usual phenomena, as because after becoming old, the skin are wrinkled, hair are all white, and it is the duty of their children to take care of them. They will not need to do any surgery. They will just depend on their children. They will take care of them. And there is gender disparities in receiving eye care also, as because male are going out for work and the female are inside the home, so could not be possible to go in the center. Health system, inadequate eye health care facilities, maintenance of eye care equipment, and utilization of services as secondary level health care. Challenges are also eye health workforce, that is inequitable and mismatched human resources, particularly in hard-to-reach, underserved area of the country. Whereas maximum population live in the rural areas and maximum doctors live in the urban area. Institutionalizing MLOP cadre. Eye care services, that is increased CSR. High volume surgery do advocate as ensuring quality surgery to increase cataract surgical coverage. So the opportunities are, our government, Ministry of Health and Family Welfare, developed National Eye Care Program, and they have given some strategy and activities to reduce cataract backlog by 2030. To provide high quality, low cost cataract surgery to eliminate backlog, that is, to increase the CSR, improve quality and outcome of surgery, provide accessible, affordable service to the hard-to-reach area, public awareness program for early detection and referral of cataract. Infrastructure technology development by strengthening existing one and at different level, and also establishing new facilities at different level. And 200 community vision center has already established in Bangladesh, and aim to develop 600 community vision center by the year 2030. One community vision center for 300,000 population, and utilization of modern technology by ensuring the supply of modern equipment to all eye care facilities. Here is the community vision center, and what Dr. Rao has said, this is not the conventional way, but this is the futuristic, I think, like that, as because from here, not only referred directly to the base hospital, but also they are screening and give the treatment with the consultation of the ophthalmologist at base hospital through telemedicine. And this community vision center situated around the base hospital, 50 kilometers around that. So patients refer to base hospital for surgery. This is one of the base hospital in Bangladesh, and doctors are doing the surgery. So human resource development and development of subspecialty, training of subspecialty ophthalmologists in country and abroad, development of MLOP, development of primary eye care worker, strengthening advocacy meeting with policy decision maker, professional bodies and community leaders, billboard, poster, leaflet, TV spot and radio program for awareness development. So improving coordination and partnership with GEO and NGO, strengthening coordination mechanism between GEO, NGO and private sector, expansion of maximum collaboration in service delivery through different agencies, private sector encouraged to take more responsibilities in providing low-cost services. Sustained demand-side financing. This is one of the special program of National Eye Care, is to provide financial support for marginalized group of people for doing cataract surgery. This support cover transport, food, and subsidy for day loss. So, in conclusion, eye health service needs to strengthen increasing effective rehabilitation will reduce social impact. More investment for preventing blindness is needed. In conclusion, I would like to say regional cooperation will enhance prevention of blindness program in Bangladesh. Need to develop strong cooperation to promote shared learning and exchange of technology. Exchanging public health experience in preventing blindness, developing opportunities for competency-based training, fostering service development network, knowledge sharing for improving quality, productivity, equity, and access to cataract services. And last of all, thank you all for your patience hearing. Thank you.
Thank you, Professor Awasan, for sharing your experiences and wisdom with us. And we hope we have got a fruitful discussion in the future as well. Thank you.
Any question or anything to discuss? Because we have some time. Maybe.
If there's no point of discussion, then we close this session. Thank you for being here.
Sir, if I can add something here, with respect to B.N. Rao sir and Madam whatever said.
You're not audible.
Hello?
Yeah.
Thank you for the opportunity, sir. I want to thank Rao sir being constructed many, care centers across the Andhra Pradesh. I was representing Andhra Pradesh, one of the care center around. I have seen in prospect of research as well, it can add some patients, rare diseases patient we can't trace here and there geographically. Probably these care centers can add wherever we found out, rare diseases, still we can trace and include them in the research, where we struggle to get the patients. In that case also, it will be very helpful to add in prospect of research and clinical research, those areas. Probably that is one of the biggest challenge across the clinical researchers to find out the rare diseases and tough cases, having the inclusion criteria, the stringent criteria. And this is one of the opportunity to tell that this will help in research prospect. Thank you so much for that, sir. Thanks.
Thank you. Yes, sir.
Actually, you're right. That's part of our thing also in our vision centers. I talked only about the service component today. And the way we document every record, even in the vision center, brings out all the information. And from the vision centers, we are now going into very vulnerable populations in the state of Orissa, for example. And actually, we are looking for what we might call what the mind doesn't know can the eye see. Right. Can we really find out something new, which was never described by anybody? I'm sure there are some problems that we don't know about that right. exist in the remote rural populations and the
absolutely correct
populations. Yeah. Certainly, we have a focus on rare eye diseases. We look for them.
Yeah, thank you so much, sir. That's what I wanted to add here. It was something great, sir. Thanks.
Again to Professor Rao. The big challenge is retaining the skilled workforce in the places. And what are the mechanisms of retaining them? Because we are facing a lot of problems for retaining them. And the second question is, how do you maintain the surveillances? Do you have the real-time surveillances from that point? And how this data entry is very important, because we are providing training, but still then data entry is always is not very quality. So that's another challenge, is how we will address this too.
What is the challenge actually? Data entry is the challenge.
Data is simple, sir. In all our primary care centers, we have electronic health records that's connected to the main headquarters. And the second thing is we have 3 levels of surveillance. One is the administrative surveillance, because 10 vision centers are linked to a secondary center, and the administrator of the secondary center provides oversight to the administration of the vision centers. Second is the optometrist at the secondary center provides the technical oversight and monitoring of the quality of the vision technicians. The third is the public health oversight provided by the public health team. 3 levels of oversight. The other thing is in terms of how do we retain them, we have a 20% dropout. They leave because majority of the vision technicians happen to be women. And once they get married, they move geographically, they go to different areas. If in another area where they move to, we have a vision center nearby, we give them the opportunity to continue the employment. But if not, they leave us. The second is what we found is we have 3 levels of career advancement opportunity. If they do well, they can become coordinator for a cluster of 10 centers. That's one opportunity. Second is they can go and do advanced studies in public health. And the third is they can become optometrists, and we support them all the way to completion of PhD if they have the competence and willingness to do it. So career advancement opportunity is a big thing.
That is very important. Sure. Okay, thank you all. We are closing this session.